Our next speaker is Mohammed Saeed Alam. His topic is medial canthal swelling. Can we move?
Good morning, everyone. So I'll be talking upon medial canthal swelling. So first of all, I'll just show you two cases. It's not moving. Yeah. So these two cases, when you closely look at them, so more or less they look similar. So both of them have a mass in the medial canthal area. So, but when we clinically examine, you see the case here has a mass in the medial canthal area, but it's a firm mass and the skin is quite puckered to it. It's going above the medial canthal tendon. When you see this case, so this patient has a fluctuant mass in the sac area, quite inflamed. So this is a common lacrimal sac swelling. A patient of nasolacrimal duct obstruction was presented with lacrimal sac abscess in the emergency. But this case, it's a mass in the medial canthal area. It can be anything. It can be arising from the lacrimal sac, or it can be a mass arising from the medial canthal tendon, in the medial canthal skin. So now, whenever you see such cases, so now you have to decide like what to do. Clinically, you have to judge whether this mass is at all arising from the lacrimal sac or not, because that is the most common site from where a mass in the medial canthal area can arise. And then you have to think whether I need to do imaging in this case or not, whether I need to start the patient on antibiotics, whether the patient will need a biopsy in the future. So all these cases, I will show you a few cases where like you will get answer to all these questions. So this is a case, 51-year-old female who has presented with a cystic swelling in the medial canthal area, has been there for around 2 months. And patient gives history of recurrent self-resolving episodes. So when such a patient gives such a history, so we think it's a nasolacrimal duct obstruction with a mucocele in that area, and patient has also undergone incision and drainage elsewhere. So then patient presents after a few weeks with this kind of a picture, and of course when we do a Rho+ it's negative, syringing is patent, so it's not a case of nasolacrimal duct obstruction. So we also did the same thing, we did an incision and drainage for the patient. This is the imaging of the patient where you see a hypertense cystic mass just adjacent to the nasolacrimal duct. So patient, as I told, patient underwent incision and drainage, but then again presented with a residual mass in the same area, and the imaging showed a residual swelling in the same area. So now we had to do something else. So we went ahead, we opened the sac area, and what did we find? So we found a cystic mass in the area of the lacrimal sac. So of course it had a super added infection, but the histopathology showed that it was an inclusion cyst right along the area of the nasolacrimal duct. So it was not a nasolacrimal duct obstruction, as we had seen in the clinical examination also, that the Rho+ was negative and syringing was patent. So this is post-excision biopsy. Patient now doesn't have any history of swelling, and of course no complaints of watering. Another case, a young female, history of recurrent swelling below the medial canthus for the past 1 year. Patient has been diagnosed with lipoma, elsewhere has been advised surgery, and swelling is progressive, non-tender. Rho+ was positive in this case, but syringing was partially patent with fluid accumulating in the sac area, which is a typical thing that we get in any case of atonic sac. So we thought it's a case of atonic sac. Imaging again showed a large hyperintense cystic mass in the area of the nasolacrimal duct. So again opened it, we went inside. What did we found? We found a large intraluminal cyst. A cyst, whether it was within the lacrimal sac or adjacent to the lacrimal sac, it was difficult to differentiate. This was the blood which was aspirated from the cyst, and histopathology showed like it was a cyst arising from the lacrimal sac area, and intubation was done. Patient also underwent a DCR, and in the post-op area was doing well. Watering had resolved. Another case, young female again with a swelling in the medial canthus area. Here you can see for the past 5 months. This is the swelling in the medial canthal region. Rho+ negative, syringing patent. So of course, again, it's not a case of nasolacrimal duct obstruction. Patient was advised conservative management, swelling persisted for 3 months then and MRI was advised. Again, MRI shows a large or hyperintense mass adjacent to the nasolacrimal duct. So we opened it up and what did we find? A large mass in the area of the nasolacrimal duct, just adjacent to the, and the mass was like, it was so much adherent to the surrounding structures, it was difficult to, to delineate the anatomical structures, the sac, the nasolacrimal duct. So some portion of lacrimal sac also got sacrificed in the process of removing it. So we removed it, managed to remove it completely and put a mini monoca stent. Histopathology showed granulomatous inflammation. It was a granuloma arising from the area of the nasolacrimal duct. So now granuloma can be anything. We screened the patient for tuberculosis. We ruled out sarcoid. Everything was negative. And this patient had, after removing of the mini monoca, had persistent watering and developed a canalicular fibrosis. Now this is another case of a young male swelling in the medial canthal area for the past 1.5 years. You see a typical swelling which resembles a kind of a mucocele. So the mass has been gradually increasing in size. Again, rho plus is negative and syringing is patent. So it's not a case of nasolacrimal duct obstruction. So again, you need to do an imaging. Imaging shows an hyperintensistic mass below the area of the opening of the nasolacrimal duct. So we open it and this is the intraoperative picture. Typically, as all you can see, it's an epidermoid cyst. That's how an epidermoid cyst looks like. So histopathology confirmed that it's an epidermoid cyst, and of course this patient didn't have any watering in the follow-up period. Another case, 35-year-old female, complaints of mass below medial canthal area here in the left eye and associated with watering for the past 6 weeks. Patient gave history of frequent bathing in the open ponds, had been diagnosed as lacrimal sac rhinosporidiasis elsewhere. Rho plus was negative, but syringing showed complete regurgitation of fluid from opposite puncta. So we thought like it might be a case of nasolacrimal duct obstruction, but then since the mass was palpable, we did an MRI and this is, a CT scan, and this is what the CT scan showed, an irregular ill-defined mass in the sac area. So we plan to open it with an intraoperative frozen section. So the moment we opened it, we saw a cystic swelling in the area, and we aspirated the fluid from the cyst. It was a pus-like thing, and the moment the cyst was removed, the syringing was patent on table. So histopathology didn't show anything, but microbiology and further DNA sequencing confirm it to be Pleurostomophora richardii. So it's a case, rare, dematicious fungus. We also published it in OPRS journal as a case report. It's a Pleurostomophora mass which presented as a case of transient nasolacrimal duct obstruction because of the compression of the nasolacrimal duct. So mass lesion in the lacrimal sac region can be a diagnostic dilemma, and sometimes they should be differentiated from benign lesions, like they present with history of hemolacria if they extend above the medial canthal tendon and if their adherence to the surrounding structures. So to conclude, it's a diagnostic challenge. Of course, the most common mass in the medial canthal area will be a mucocele resulting from a nasolacrimal duct obstruction, but then again, other causes of lacrimal and perilacrimal masses need to be considered in all these cases of medial canthal masses. Imaging plays a vital role, and role of basic history and clinical examination cannot be underscored. Thank you.
Excellent